us. Dr. Namrata, please.
Thank you, and I'm sure there are going to be great discussions and deliberations, but I'll be just telling you about how to manage adult myopia with the refractive surgeries. And this will be again followed by contact lens, orthokeratology, and management by spectacles. So I think type of refractive surgery is important. It could be cornea-based or lens-based or bioptics, which includes both. And dilemmas are not in doing the surgery. I don't think there's too much skill involved in the surgery. Dilemmas are, is the patient suitable for refractive surgery, and which surgery is best for the patient. So the FDA has given very clear guidelines for surface ablation and LASIK. It is -10 diopter sphere and 4 cylinder. And as far as hyperopic is concerned, it is +4. For SMILE, it is up to -8, and now even up to 2.5 diopters of astigmatism. And phakic IOLs is as shown -3 to -20, and +3 to +10, and 6 diopters of cylinder. And refractive lens exchange possibly can be done for all ranges. So the ideal candidate, you do need that the age should be at least 18 years. For SMILE, the age is, for lenticular procedures, it is 21 years. For ICL, 21 to 45 years. And for PRK, again, at least 18 years. So the ideal candidate would be a person who's had a stable refractive error, less than 0.5 diopters change in past 1 year, no, not pregnant or breastfeeding, no systemic or autoimmune disease, adequately counsel, and no ocular comorbidities. Absolute contraindications are, of course, ectasias, or those who have a propensity for ectasia, and relative contraindications are many, like dry eye, herpes infection, etc., and is left to the discretion of the operating surgeon. It is important to do a good ocular examination, but I think it is very important to do this clinical investigation, and more so the corneal pachymetry and the corneal topography, as well as wavefront analysis if required. And there are at-rest corneas, so if you have a keratometry which is high, or if you have inferior superior asymmetry, or if the corneal thickness does not allow you, it is less than 470 microns with normal topo, or less than 500 microns with abnormal topography, and anterior elevation and posterior elevation likewise are more than 12 or 17, then one can't do refractive surgery. Bell-and ratio enhanced display is also important, and the difference map, again, we look at the band and also the progression, the thickness profile, and the progression in terms of the bad values. Now, which surgery is most suitable would depend on residual bed thickness, corneal thickness, and the steepness of the cornea. And this is basically the guidelines. So if the thickness and the keratometry allows you, then you can do cornea-based procedures. If it does not, then you have to do the lens-based procedures. And again, higher order aberrations, if it is less than 0.3 micron wavefront optimized LASIK, more than 0.3 micron wavefront guided LASIK, or topo guided LASIK has to be done. Now, just to give case examples, 21-year-old female with residual bed thickness which is more than 300, with keratometry which is optimum, percentage tissue ablation which is less than 40%, and a topography map like this, one then has to see the pupil, the thickness at the pupil center and the apex of the pupil, and the difference between the pechy apex and the thinnest location is 17 microns. So if it is more than 10 microns, it is significant. So in such cases, if you look at the bad also, you have a red and a yellow value here. And these are the cases where you would like to observe and reassess for stability of the topography after 6 months. Now, case scenario 2 is you have a simple refractive error with the thinnest pachymetry of 550, 555, which again allows you, and keratometry also, which is allows you to do the refractive surgery. But the patient is from armed forces, and in these cases, we would rather plan a PRK rather than a LASIK surgery. And I think there is nothing too much to PRK. We all know how we do it. The alcohol debridement is done first, followed by the laser ablation, and then subsequently followed by the bandage contact lens application. We can also do a transepithelial PRK, where the laser itself does the removal of the epithelium, as is shown here, and then subsequently the laser ablation is done and BCL is placed. The case scenario 3 is this, where 24-year male for cosmetic purposes with -4 sphere and -1 cylinder. Thinnest pachymetry also allows you to do it. Keratometry is fine, and then one can plan LASIK. But this is a case in which the residual bed thickness is with 110 microns is good, but if you look at the residual bed thickness with 100 microns, the percentage tissue ablation allows you to do it. It does not allow you to do it. Then in those cases, it is best to plan a flap which is thinner, because you know that the residual bed thickness would be greater, rather than a 110 micron flap which will eat away 10 microns more. So I think again LASIK is a procedure which is known to all of us. You can use a microkeratome, which is now almost very few people use it. And after creating the flap, the laser ablation is done. And then the flap is again reposited back. Now this is a case scenario 5 again, where RSBT is good. The percentage tissue ablation is also good. The thinnest pachymetry is 512 and 506. So here you can do both the procedures, either femtosecond LASIK or SMILE, that is the lenticular procedure. This is a case where we would want to do a SMILE procedure because this patient is a football player, and rest of the parameters are allowing you to do the surgery. But the only fact that the occupation is different, so you change your procedure. Now this is case scenario 7, where again being done for cosmesis purpose, but notice that the Sharma is a little less. So in this case again you would start for lubricants and will possibly do a SMILE surgery, because that causes a less amount of dry eye. So I think again everybody knows how the procedure is done. The lenticule corresponding to the refractive error is taken out, and this is how the myopia is being corrected. The last is the phakic intraocular lens for high grades of refractive error, and again in this the phakic lenses are available. One can use any company that one wishes to. This is the ICL which is being implanted for the high amplitude of refractive error. And again, this is a simple surgery to do. But I think more important is always the decision for the surgery rather than the simplicity of the surgery. And this is the next case scenario 8. Again, high refractive error, the RSBT and percentage tissue ablation does not allow you to do, so you plan for ICL. This is yet another case where the refractive error was -8 with -1 cylinder, other eye was -3. I would rather do a ICL both eyes so that the quality of vision is similar in both the eyes. This is yet another case where RSBT does not allow you to do surgery, and post-op also is going to become very flat. Refractive error is very high. So you may plan to do bioptics, that means LASIK as well as phakic intraocular lens. And again, this is an example of bioptics, which some people may or may not want to do. Bioptics is again a surgery which is really not very popular. In case where in a patient who's nearing, I shouldn't say old age, but may have cataract in future, can be counseled for other procedures as well. If you have pure cylinder, then one has to be careful, because if the Kmax is high, then these are the patients who may go into ectasia, and ablative procedures should be avoided. And again, in this case, both eyes ICL, because RSBT or residual bed thickness does not allow you to do so. So I think refractive surgery has evolved significantly, and like I said earlier, the decision is more important than the surgery itself, because the patient also needs follow-up frequently in the post-op period. So thank you very much for your kind attention, and I would like to invite all of you to Asia Pacific Academy of Ophthalmology next year in Yashobhumi, Delhi, April 3rd to April 6th. Hope to see you everyone there. Thank you so much for your attention.
Thank you, Namrata. It was, I think, everything with indication and everything she has told us. Any questions from the audience?
So if you feel like removing it or for any other untoward incident you have to remove it, then in that case there are two options. One is you can let the ICL remain in the fellow eye and use a contact lens in the eye from which the ICL has been explanted, provided that the lens is clear and the cornea is clear and that sort of a problem is not there. Second option is, again, that option you have to give it to the patient if the patient wants the bilateral explantation of the ICL. But from the surgeon point of view, I think we should try to rehabilitate the patient with sir, with the current phakic intraocular implants which are available, it is said that they don't get it earlier. It is possible. So when they get cataract, we can explant the ICL and then do the cataract surgery. There is no problem with that. It comes out very easily. It's like a. Thank you, sir.
Dr. Namrata, just one question. Just one, have you, the research going on and the studies, have you tried to do, because higher myopia, maybe minus 12 or 18 you can't do, do you do partial LASIK also in that cases and then you can specs, for example, how much is the maximum according to the patient, the corneal thickness and the amount of myopia?
So the maximum I think that you can correct as per the FDA is -8 diopters, but from what I understand, sir, you are saying that do you undercorrect these patients with the refractive surgery?
What I mean is -12 and the patient, because a lot of people refuse -12, you can't have LASIK. But can we do some partial, because a lot of patients who are asking, ki sab kuch to chashma kam ho jayega, you know, like that. So, because
then we, of course, have to counsel
because
them.
Because high myopia -12, you reduces 3 lines of vision because you get, you know, the vision goes less because of the high minus lenses.
No, that is because, sir, at least so many years of
-12, -13, whatever it is. -12 ka chashma lagne se.
So as such, for reducing the thickness of the glass, we cannot propose LASIK and should not propose LASIK. But if the patient is extremely motivated, you may counsel the patient that the spectacle independence will not be there.
Because, you know, but these high minus, मैं about 10 की बात कर रहा हूँ, you know, you have a lot of prismatic effects and, you know, lot of vision, the acuity goes down. So, lot of people are asking कि साहब ये मोटा चश्मा हट जाएगा क्या? So, -5 भी अगर रह जाता,
I would rather counsel them for contact lenses than for doing.
They are not ready for contact lenses. वो बात है, contact lens हो तो कोई फिर तो कोई बात ही नहीं है. Then there is no problem, you know.
Sir, in my practice, I don't think. I mean, I must have come across only 2 or 3 patients who would have said like what you're saying. But then I would counsel them and do it. But I do not remember having done it for anybody like that.
वो तो सर 100% तो कुछ नहीं ले सकते.
Spectacle independence is only for the period till the time you are not presbyopic. -6 after LASIK has.
नहीं, 1 आई या both आई सर? तो फिर तो क्या प्रॉब्लम है? स्पेक्स लगा ले, +4 में कोई दिक्कत नहीं है.
No, sir, we have to also look at the keratometry value in these cases, because -6 means you are going to make the patient flat and +4 means that you are going to make the patient steeper. And hyperopia, you don't correct more than +4, because for every diopter of hyperopia, you are increasing the steepness by 0.75 diopters. So, yeah, so if you have a patient who has got 44 diopters of K and you do +5 hyperopia, you are actually making him almost 49 or 50, which means you are inducing ectasia. So that is why hyperopia more than 4 you never correct.
Namrata, last question. You have told about the age, what time, we should do. So we should wait for the progression of the myopia to stop, or we can do in between the LASIK surgery or any other.
No, so if we are very stringent with this, that the refractive error of the myopia should be
Stable.
stable for at least 1 year, and the age of the patient should be more than 18 years.
The another question is, can we do the LASIK surgery in pediatric?
So there are reports, I think Dr. Yogesh Shukla sir would be able to answer that better, but there are reports because of the amblyopia or anisometropia, if it is there between the two eyes, then people have done it, and also done it because they fear that amblyopia may occur. So
But the problem with the
Basically, Shukla sir, Namrata madam, there is no any reference anywhere. Now,
no, there are references, sir.
There are studies, sir.
There are a
There
lot
are
of
very
studies.
small case
They have
series.
tried in 10 years, 12 years, maybe उन्होंने किया है, but the myopia progressing too much, and they have tried to do. But the problem is the corneal anatomy and the corneal physiology is so different in a child, you know, because that's why we wait for 18 years. So it's so different that the reactions of LASIK have been a lot of problems, a lot of haze, and you know, things have happened. So they are not doing, because we have other ICL, we have ICL.
it means
Now
in
it has
pediatric we should not do. Why I have asked, I will tell you. The case is going on in the court. The myopia is corrected in both eyes at the age of 9 years in 3 children. And we are answering. But see, there is no any, can say, reference, proper reference, that where the court will be satisfied for that. But I think we should not, I think, do the such type of thing in the pediatric, because whatever. हाँ, वही प्रॉब्लम होता है, तो we should not.
Experimental है ना sir, it is
हाँ,
still
so we
experimental.
should not do
So-
such experiment on the pediatric cases. Thank you, thank you, thank you.
Thank you, Namrata.